Topic of my lecture today is bronchi and bronchioles. What is their anatomy? What is their pathophysiology? What diseases might affect them? Which diseases might affect which structures, which anatomical structures, and how do we to get above them? First of all, we have to talk about the anatomical structure of a lung so that we might know better that which disease is affecting which structures. As we all know, we have a pair of lungs. On each side, we have one. So let's get into the basic anatomy of the lungs and get to know those structures that get affected during different diseases so that we might get to know that what changes are occurring during those diseases and what is the basic of that pathophysiology. First of all, there's this interpulmonary bronchus, which is the basic structure coming right down. It is supported by a C-shaped cartilages. These cartilage plates are there to support the structure so that it does not collapse. Sometimes it does happen that the pressure of the air, which is leaving the whole system, might lead to the collapse of the whole system, might lead to collapse of that bronchus or alveoli. So these structures, cartilage plates, are here to protect the trachea and interpulmonary bronchus. On the other hand, in alveoli, the pressure does the same work of not letting it collapse. Then comes smooth muscle fibers, which are there to protect it, which are there to give it strengthening force, which is required by this whole structure. Then comes bronchi, which are the two bifurcations of this whole system. They go and start branching off into bronchioles and then terminal bronchioles, and then at the end they lead to alveoli and alveolar air sacs. Then there's pulmonary vein. Then alveoli comes in, which is the basic unit of the whole structure of lung. We have to get to know alveoli very thoroughly so that we might know how the gas exchanges are occurring and what pathophysiology might affect them. Then interalveolar septum is there. This septum separates them from one and each other. It is very elastic in nature. It has a recoil power, and it is the basic structure which supports the whole process. If interalveolar septum is gone, so does all of the work of the lungs. Then comes visceral pleura, which protects it. Then pulmonary vein. Then comes terminal bronchioles, which I already told you about, that bronchi are divided into bronchioles, then further into branches, and then come terminal bronchioles, and then come alveolar air sacs. So the terminal bronchioles and the air sacs are together the respiratory unit, which is leading to that respiration which is needed, with that gas exchange which is needed inside the body. All the other parts and all the other places, all the other structures are actually conducting zones. Then comes respiratory bronchioles, as I already told you. These are respiratory bronchioles, so the gas exchange occurs through them. Then comes alveolar elastic network, which gives them elasticity. And then comes alveolar capillary network. Whole capillaries surround the alveoli so that gas exchange might occur. In this gas exchange, oxygen is being taken up by the blood and carbon dioxide is being shunted off the blood. That carbon dioxide goes off to the alveoli, then goes into terminal bronchioles. From there it goes to bronchioles, bronchi, and then it leads to that nose and mouth structure, and the body gets rid of it. So in order to get to know everything, first we have to know what are the congenital abnormalities which might affect the whole process, which might affect the gaining of these lungs even, which might affect the pathological behavior of lung from the very birth. Basically, we will talk about 4 or 5 pathological, congenital pathological forms. First of all, there's bronchial atresia. You might ask, what is bronchial atresia? As you can see, first of all, let me show you on this diagram what is bronchial atresia. This is bronchial atresia. How do you define it? Bronchial atresia is actually a part of the lung which was not given the blood supply which was required for it. It's a proximal part of a bronchus, which is entirely different from the whole lung system because its blood supply was compromised, and this area has led to atresia. That's why it's called bronchial atresia. It can lead to many pathological forms, but in some cases, it's not even diagnostic. We don't even get it unless you go for X-ray or some diagnostic testing, and then you find it. So, which area might be affected by this disease? Any area on any lobe on any side of the lungs might get affected. But the most prone area in this disease is left upper lobe of the left lung, which is called, let me show you actually, which is called lingula. Lingula is a structure which is present on the left upper lobe of the left lung, and it is the most prone structure for bronchial atresia. When bronchial atresia happens, this place is always hyperinflated. As you can see it right here, it's always hyperinflated. It's never, empty or something. It's always hyperinflated. You can just go for it and find that this place is always hyperinflated, whether inspiration or expiration is happening. So this might be bronchial atresia. This place is undergone atresia. This whole part of bronchus has undergone atresia. So this is how you're differentiated from other normal lung parenchyma. Next on, we have pulmonary hypoplasia. What is pulmonary hypoplasia? Pulmonary hypoplasia is actually, you can say, embryologically, if the lungs are not developed properly, if the lungs are not of their normal size properly, that's called pulmonary hypoplasia. In this condition, the lung parenchyma, the lung cells, the bronchioles, the terminal bronchioles, the alveoli are not in their best form, either in the best form or in the best numbers. They are just not enough for gaseous exchange to take place. So the sustainability of life is not possible. In many cases, it's not even possible for life to sustain in this condition. What might be the causes of this condition? Maybe it's because of diaphragmatic hernia. Ever heard of it? In diaphragmatic hernia, the contents of the abdomen start moving upward. They move into the thorax. They lead to accumulation of all the structures in the thorax, which will lead to a great amount of pressure on the lungs. And the development process of the lungs will be compromised. And this is how it can happen. This is how pulmonary hypoplasia can happen. As you can see in this condition, this X-ray shows the pulmonary hypoplasia of right side with right mediastinal shift. Why would mediastinum shift to the right side? Because there's empty space present there, because there's place to go there. It's being pushed towards the right. That's how you differentiate it. That's how you see it on the X-ray. Next on, we have cystic adenomatoid malformations. What are the cystic adenomatoid malformations? It's actually a cyst which appears on the chest cavity, inside the chest cavity, during the fetal period. Most probably it appears just before the birth. But it keeps on increasing in its size. It keeps on enlarging. And at the end, it might contain the whole lung. It might affect the whole lung. It might surround the whole lung. So how do we diagnose it? How do we know that we have cystic adenomatoid malformation? Actually, when you go for an in utero ultrasound, you might find a bright light on that side of the chest. What is a bright light on that side? It's actually that cyst, which contains either water or it always shows white on the ultrasound. So it's very easy to get diagnosed. Then there are options that whether we go for the surgery, whether we wait for it, whether the person will be normal or not. So in some cases, cysts are so benign that they remain of the same size. They don't affect the baby. So we wait for the baby to get delivered, and afterwards we go for the surgical process of draining it. But in some cases, the size keeps growing and growing. What are we to do then? We give immunosuppressive therapies, but specifically we give steroids to retard the growth of it. And in some cases, when the size of this cyst is growing so dramatically, we go for the surgery, open surgery for the cyst, so that we can drain it and it might not affect the lungs and the proper functioning of it. But in most of the cases, a person comes out totally fine, lung functions are totally normal afterwards as training. So it's not big of a matter, but you have to know that in utero, you have to get an ultrasound to check for cystic adenomatoid malformation. This is how it shows on the histological patterns. As you can see, it's a cyst. It doesn't have any proper functioning or working unit or structure units. It has its blood supply outside of it, but it is not working as it's supposed to. It's not working as lung parenchyma. It's a cyst which is just surrounding the whole thing, which is just there, and it's enlarging in size because it's getting its fair share of blood supply and nutrients. Next on, we have bronchial cyst. How do we define bronchial cyst? Bronchial cyst is actually a malformation of the bronchial tree, that whole tree, bronchi, bronchioles, alveoli, that whole tree is affected. It's a congenital malformation of this tree which leads to a cyst formation, a mass formation, which compresses the tissue. As it increases the size, it compresses the tissues. It's called bronchogenic cyst. It might affect the whole lobe, or even in some cases more than a lobe. As you can see, this is a bronchogenic cyst, a proper bronchogenic cyst which contains holes and the blood supply and the pus, as you can see, and it's been drained already. On histological slide, you can see bronchogenic cyst as this. It's epithelium, and then there's that whole contents of that cyst which are present inside. Next on, we have extralobar sequestration. It's a very unique condition, extralobar sequestration. It's actually a lung tissue which is not connected to the lungs. It is a lung tissue which has its distinctive pleural investment. Distinctive pleural investment makes it very unique. It gets a blood supply from anomalous arteries. Though the systemic artery, it doesn't get its blood supply from any kind of pulmonary blood vessels. No, it gets its blood supply from anomalous arteries, and it drains its venous supply into zygous or hemizygous blood vessels. As you can see, it gets its own blood supply. It's not getting any kind of blood supply from here. It's totally differentiated structurally and physically on the basis of its physiology, on the basis of its anatomy. It's totally separated from the body of the lung parenchyma. It has its own venous supply. And when you get a histological pattern, this is how it's shown on the histological slide. So in some cases, we go for the surgery, we have to remove it, but in some cases, we just let it go in case it's not affecting the other parts of the lung. Next on, we have interlobar sequestration. It's actually a non-functioning part of the lung tissue which is present inside a bronchus. It has no connection with that whole tree system, that whole tracheobronchial tree system. It does not get any kind of blood supply for them. It does not drain into them. It has its total entity separate from the whole thing. It's present right here. And as you can see, the arterial supply is coming from the other structures. Then comes the bronchial connection. It's totally differentiated on the basis of its anatomy, its physiology. It's not working as a lung tissue. It's not working as a lung parenchymal tissue. It just goes on. It happens in adolescent. In adolescent phase, it happens inside a body. It can happen anytime inside the lungs throughout your age. But most probably the perfect age for interlobar sequestration to happen inside a body is the adolescence. This is how you see the interlobar sequestration on the histological slide. As you can see, it's getting its fair share of blood supply, but it's not working as a lung parenchymal tissue or respiratory tissue because it does not have any kind of cells which may participate in the gaseous exchange. Next on, we have atelectasis. What is atelectasis? As we talked from the very start that C-shaped cartilages are there to protect the whole trachea so that it doesn't collapse. That concept is going to be applied here. Collapsing lung is called atelectasis. It can be a whole lung, it can be a bronchus, it can be an alveoli, it can be a group of alveoli, it can be anything. Any part of the lung, any part of the lung parenchymal tissue which gets collapsed leads to atelectasis. This process is called atelectasis. So there might be many causes of atelectasis. In some cases, some imagine that it's because of some other systemic disease like cystic fibrosis. That might be the cause, because what happens in cystic fibrosis? Exact same pathology which leads to the collapse of the lungs, collapse of those alveoli. And that's how we get atelectasis. That atelectasis might be secondary to cystic fibrosis, but no matter what, it leads to atelectasis. Further on, we have a very important part of obstruction. Atelectasis, the major cause of atelectasis happening inside of our whole community is the foreign body or obstruction of some kind. This is how you see it. This is a blocked bronchiole. Blocked bronchiole means that this air, which is present right here, is going to get consumed. All of that air will be consumed through alveoli and all of that gaseous exchange will happen. And then there's no air at all. And this place is blocked. So there's no way that that air can burst through. That air can leave the whole place. So if that cannot leave the whole place, that air is going to be used. And after that, there's no air. It's just empty space. There are two very important things you must know. That what's the basic instinct of an alveoli? The basic instinct of an alveoli is to collapse. What's the basic instinct of the chest wall? The basic instinct of the chest wall is to expand. These two forces are kept in check with each other so that we might have a normal body. In some cases, when one of the forces gets bigger or higher, you might see barrel chest in some patients because alveoli collapsed. What is happening to the chest? Chest is going to go for the instincts and it leads to barrel chest. So in the case of obstruction, when the obstruction did happen, the alveoli didn't have any air. It has empty space and some carbon dioxide which is roaming around. So it's going to collapse and it's going to lead to atelectasis, the term we talked about. So atelectasis might be of a single alveoli, it might be of a bunch of alveoli, it might be leading to the atelectasis of a bunch of alveoli and then even a bronchus, even a lobar, even a lobe is involved. So how do we differentiate it? What's the type of the atelectasis? Type of atelectasis or obstruction. It's also called resorption atelectasis. I just told you obstruction can happen. Any foreign body can come up and it can lead to obstruction, and that air which is already there in the lung may get consumed and there might be no air coming through afterwards because it's completely blocked that lumen which was there to provide us the air with. So this is resorption atelectasis which happened due to obstruction. Then comes the passive atelectasis. What do you think passive atelectasis mean? Passive atelectasis means something is there which is pushing the lungs. The basic example of it is pulmonary effusion. Pulmonary effusion is a basic cause of passive atelectasis because it can also happen in pneumothorax. For example, a patient is having a pneumothorax, air is rushing through, it's pushing the lung, it's pushing that whole area on the side so that area is not able to communicate with the blood vessels and anything. So that area might collapse. And this is the major example of it. In pneumothorax patient, we're going to have a passive atelectasis. Then there's contraction. Contraction might happen in some cases where there is some systemic disease involved. where there's some systemic processes involved which might lead to the contraction of the whole structure. Then comes compressive. In compressive, it means if air is leaking through, if blood is leaking through, if any kind of adenomatoid tissue is leaking through, it also leads to compressive kind of atelectasis because it compresses the whole tissue. Then comes the pathology of atelectasis. How do we define that what happened during the pathology of the atelectasis? This is the histological diagram. Now let's get to the clinical features. But before getting to clinical features, I would like to explain that look at this slide. You can see all the structures right here, but then comes the gaps. You can totally differentiate the cells which are functional right now and the cells which are not. Next on, we have clinical features of atelectasis. First of all, what are we going to have? We're going to have shortness of breath because the alveoli just collapsed. The alveoli are not working. Maybe 10%, maybe 20% of the alveoli are not participating in gaseous exchange. When they won't participate in the gaseous exchange, you would want to take more air inside the body so that you can compensate for that alveolar loss. You can compensate for that place which was destined to be for the gaseous exchange. Now you're taking more air and the respiratory rate is rising because you have to oxygenate the whole blood. So first of all, if a person experiences atelectasis, first sign which is going to happen is shortness of breath. Second, person is going to wheeze. Why does wheeze happen? Mostly it happens in the patients who already have a pathological form of lung disease, and it may happen in those patients which does not have any kind of pathological disease. Wheezing occurs because patient is not getting enough oxygen. Patient is gasping for oxygen. Maybe it's 50% of the alveoli. Maybe due to obstruction, a whole lobe is involved. So patient might be gasping for air. Then rapid shallow breathing. A person might not get as much air as it's needed through even shortness of breath or wheezing. It will lead to rapid shallow breathing. Person will be going. So this kind of movement will go on and on and on until the need of the body is being met. That whole blood is being oxygenated. Then sudden drop in blood pressure. Sudden drop in blood pressure will happen because all the blood that was rushing through those alveoli to get oxygenated now knows that there's not enough oxygen, there's not enough air inside the lungs for the whole blood to get oxygenated at the same speed. So the blood pressure will drop, so the blood passes through the alveoli slowly, so that it might get the better chance to get oxygenated. If it's passing very fastly, it won't get oxygenated at all because there's not enough oxygen in the whole system. So the blood pressure drops to compensate for the atelectasis. Then there's sharp chest pain. That sharp chest pain arises at the exact point where atelectasis happened. Because it's very painful process. It's like something is crushing you from the inside. So there will be sharp chest pain inside the body, inside the chest. Then come persistent hacking cough. Person will be persistently coughing, persistently hackingly coughing because he's not getting enough which is required for the body. Next one, we have bronchitis. What does the term bronchitis mean? Bronch means bronchi or bronchiole, but in this case, bronchi. Up till this point, bronchi, it means trachea came, divided into two bronchi, so the disease is affecting that bronchi. It's not going further, it's not going upward. Itis means inflammation, so it means inflammation of the bronchi. So why that inflammation happens? Let's get to it then. As you can see, these are the normal bronchial tubes. These are the normal bronchial tubes. And in case of bronchitis, this is what it gets to. These are inflamed bronchial tubes. They are mildly functioning. They're not up to their maximum speed. They're not up to their maximum optimum function. So we have to get to know that what pathophysiology led to this condition. What happened which led to this inflammation of the whole bronchial tube? Let's get on to the pathogenesis of the bronchitis. First of all, we have to know the etiological factors which may lead to bronchitis. What are the precipitating factors? There's one very major precipitating factor for bronchitis. It's smoking. Smokers tend to have bronchitis once or twice in their lifetime. If they keep smoking that 1 or 2 packs of cigarette every day, they might get bronchitis. So what is the pathophysiology of the bronchitis? I would like to tell you that there's a whole membrane system inside the respiratory system. First of all, in the bronchi, the epithelium is lined by a pseudostratified columnar epithelium, which is ciliated. Underneath that, there's lamina propria, in which the blood vessels are present, which will supply the whole system. That's where the blood supply comes from, lamina propria. Underneath that, there are 2 cells present, which are eosinophils and basophils. And they're going to produce mucus. And those mucus producing cells, the goblet cells and other cells which produce mucus, they receive the message that, okay, smoking is taking place, so we have to do something. Because smoking contains a lot of debris. So the whole system is a must that it should be kept moist, so that the air before reaching the alveoli should be moist. So to keep that air moist, we have to line the cilia with mucus all the time. But when a person is smoking, those cells which are going to produce mucus or get hypertrophied. Their size increase. Mostly in normal person, that organelle contains 40% of the whole structure. But in a smoker or even in bronchitis, when that structure has to produce so many mucus that it has to line up everything, it has to extra line up somehow, its size goes on to more than 50%. It's called Reed index. You have to remember it. So that's how the pathogenesis works. So let's get into it. First of all, there's phagocyte migration. We saw pollutant, phagocytes are going to come in. What will they happen? What are they going to do in this whole process? What they're going to do is they're going to release the pro-inflammatory mediators. Those pro-inflammatory mediators are going to go into the storage in mucous membranes, which will lead to 2 things, actually 3 things. First of all, respiratory tract mucous membrane direct impairment will happen. Then vessel reaction will happen, in which the vessel will get inflamed because infection is happening, which will lead to vasodilation and increased permeability of the vessel wall, which will lead to exudation because exudates are being formed, and mucous membrane edema. So 2 things happened up till now, that phagocyte migration happened, then pro-inflammatory mediators were released, respiratory tract mucous membrane impairment happened, and then mucous membrane edema happened because of the exudate and vasodilation. Afterwards, there's bronchial hypersecretion. That hypersecretion is of what? Mucus, I just told you. Mucus is being hypersecreted because we have to line those epitheliums. So this is how it's seen. So blood supply, we can see that enough blood supply is being produced, enough mucus is being lined up with. All of that structure is going to lead up to the inflammation of the bronchi, which is called bronchitis. What are the clinical features of bronchitis? First of all, patient will complain you for weakness. Why does the patient complain of weakness? Because he's not getting enough oxygen. That whole area is under the attack of an infection. He's not getting enough oxygen. He feels lethargic. He comes to you with weakness. He'll come to you with cough because it's an infection and patient might be coughing. In some cases, it will also present with headache, and that headache might be secondary to that cough. Then comes fever. Because of infection, there will be fever, but it will be low grade fever, it won't be high grade fever. Then comes rhinitis. Rhinitis is always associated with bronchitis. So whenever the word bronchitis comes in, you have to know the rhinitis. Because in some cases, it's all of this is happening because of hypersensitivity reaction. So that might be the cause of rhinitis. And then there will be chest pain because that whole infection thing is going on, air is being trapped, it's difficult to even breathe. So the patient will also complain of chest pain. Next on, what will happen in a chronic bronchitis? How do we define that it's chronic bronchitis? There's a parameter of it. If a person gets bronchitis for 3 months in a year, for 2 consecutive years, it's called chronic bronchitis. It means that person has to get bronchitis at least 3 months out of a year, consecutive 3 months out of a year for 2 years. Then we are to label that patient chronic bronchitis. So normally, this is how the bronchi looks like. It's layers of muscles and its lumen is large, and then there's mast cells present. In obstructive chronic bronchitis, this is what we'll see. And a lot amount of mucus, small lumen, and a lot of cells which are happening to be there because recurrent infection is happening. Inflammation and swelling, you can see inflammation and swelling is happening, these goblet cells, and then there's a lot of mucus around. Thick sticky mucus blocks up the airways rather than clears because its ciliary work is not even happening. If it's even if it's happening, it's not up to that mark to clear all of this mucus. So this is going to start to block the airways, and in some cases it becomes into that condition in which a mucus plug is formed, and that leads to obstruction. And that may lead to atelectasis in some cases. Now, what is bronchiolitis? I already told you, the name gives it away. Bronchitis means the inflammation of bronchi. What does the bronchiolitis mean? Inflammation of the bronchioli. Bronchiolitis, bronchial inflammation. So as you can see, this is a normal lung, and you can see this is bronchiolitis because it's happening at the level of bronchiole, and at the level of bronchus, it's bronchitis. In pathogenesis of bronchiolitis, we have to know the basic etiological factor for bronchiolitis. RSV, the virus RSV, is the basic structure, basic organism which leads to the pathology of bronchiolitis. It can also be adenovirus. It can also be Haemophilus influenza. But 80% of the cases, it's always RSV. RSV leads to the whole pathological consequence. As the RSV reaches there, alveolar macrophages try to engulf it and then release tumor necrosing factor alpha and IL-6 cytokines are released, which lead to epithelial barrier, and chemokines are released, and further off the MLP1A, as you can see right here, 1 alpha is released, which acts on it, and the airway inflammation occurs inside of it. Then airway edema and mucus production will further lead to wheezing, atelectasis, and hyperinflammation. This is the whole pathogenesis of the system. That first of all, RSV came in, it is engulfed, or at least been tried to get engulfed, and then all of these mediators were released, and that led to wheezing, atelectasis, and hyperinflation. Why do you think atelectasis is happening? Maybe because of obstruction, maybe because of pathological disease which is happening, maybe because of infection. In some cases, infection may lead to obstruction. Infection is so severe that it went on and destroyed the alveolar spaces, and somehow it led to obstruction. And in some cases, obstruction will lead to infection, because if obstruction is happening, that air is always there, and maybe those microorganisms start their work and it leads to infection. So these are always interrelated, obstruction and infection. Furthermore, we have bronchiolitis pathology as histological screen. As you can see, the focus of it, as you can see, the blood supply of it, all of it is a histological pattern of bronchiolitis. So what are going to be the clinical features of bronchiolitis? First of all, the patient will have frightened look. Why does the patient have frightened look? He's not getting enough oxygen. He's panicking right now. He does have pale skin because not enough oxygen is being taken up. So deoxygenated blood is roaming around. Bluish nail beds. Yes, because of that cyanosis, because of that low oxygenation inside the system. Rapid belly breathing, because alveoli are going through atelectasis, and due to that, body is going to use the accessory muscles to get that respiration going. Flared nostrils, and then there will be skin pulls in on neck and chest. They all pull in because of atelectasis and all the pathological things going on inside the lungs. Then comes bronchiectasis. What is bronchiectasis? Bronchiectasis is actually, we can show you on this diagram. Bronchiectasis is a permanent process. All of that are infections. All of those are infections which can be dealt with. Bronchitis can be dealt with. Bronchiolitis can be dealt with. But bronchiectasis is a process which is permanent. It's permanent dilatation of the normal airway. As you can see, this is the normal airway. But what happened here? The permanent dilatation happened. Look at these fibers. Tear happened. So this is permanent dilatation of the blood of the airway, and this is called bronchiectasis. So what's the pathogenesis of bronchiectasis? First of all, there will be an initial infection. Initial infection will lead to what? We all know it will lead to inflammation and cytokine release, and neutrophil enzymes and bacterial products will be released to compensate and to counter that infection which is going to happen inside the body. Due to which bronchial dilatation and airway destruction will happen. Because airway destruction is happening because protease is being produced. That protease might be affecting the epithelium. Other factors are being produced which are toxic to the epithelium. A lot of processes are going on which will lead to airway destruction and bronchial dilatation. This will lead to impaired mucociliary clearance. Now, mucociliary clearance has stopped. So what does that take us? Increased production of mucus is happening, and then impaired mucociliary clearance is happening. So there will be a big sum of mucus lying around inside the airway, and this will lead to block that whole airway. Then airway mucus hypersecretion and obstruction will happen. As I told you, as mucociliary clearance is not happening, then airway mucus will hypersecrete, because to compensate with that infection, it will hypersecrete. But as there is no mucociliary clearance, it will just start accumulating. It will just start obstructing afterward. It will just start converting into those mucus plug we talked about. Afterwards will happen microbial colonization and infection. As there's a mucus secretion, hypersecretion, and then there's obstruction, then comes the infection. Because I already told you, they're always correlated, infection and obstruction. Whenever there's obstruction, infection is going to happen because there's no ventilation is happening. That air is trapped. That's perfect for microbials to colonize. So which organisms are basically and most importantly going to cause secondary infection? Haemophilus influenza, Pseudomonas aeruginosa, and Staphylococcus aureus. So all of this process will lead to what? Further bronchial dilatation and airway destruction. This is how it started, but at the very minute level. But now it has achieved that level that I already showed you on the slide. That it's wide now. And what do you think will happen to the functional capacity of bronchi? Will it increase or decrease? I think decrease. What if I ask you that I'm going to blow in a straw and you have to put a hand on the other side? And let me tell you, if you feel that, if you get that, you will easily get that. You will easily feel that on the tip of your finger. Now, what if I tell you that I'm going to blow into a big pipe, a size of my pipe, and you have to stand on the other side and you have to feel that air coming through, feel that air coming out of my mouth? You won't even feel it because after a certain limit, the air is going to swirl. It's not going to go into the laminar way. So the functional capacity of the bronchi is compromised. Getting onto the pathological diagram of the bronchiectasis, you can see in some cases there are none, but in some cases, as you can see, these are big holes present inside the lungs. These were not supposed to be this big. This happened because of bronchiectasis. Their size increased with time, with this infection. Next one, we have types of it. It may be cylindrical at the end, it may be varicose, it may be cystic. It can be any of these types. But basically, they are going to be arranged in cysts rather than cylinders. Next on to a syndrome which is very much related to these diseases. Kartagener syndrome. You might be wondering what Kartagener syndrome is doing. It's a hereditary syndrome. It is an autosomal recessive disorder which is present inside the body. And what it's going to do is it's going to affect the cilia of the body. That cilia work will stop. So where does it stop? I mean, where does the cilia lie inside the body? Ear, nose, throat, inside the sperm, inside the lungs. So it will lead to infertility of that person because the sperms are not that motile, cilia are not working. Next on, recurrent ear, nose, throat infections and recurrent chest infections are the basic effects of Kartagener syndrome. It also leads to a triad of three basic pathologies, which are situs inversus, number one, situs inversus, number two, chronic sinusitis, and number three, bronchiectasis. This is a classical triad which is present inside a Kartagener syndrome patient. As you can see, this is Kartagener syndrome. Mucus is accumulating, but there's no ciliary work, so it won't be gotten rid of. It will just accumulate and lead to mucus plug and lead to obstruction and lead to infection. As you can see, it's just accumulating, it's not being taken care of. So what we learned in this whole lecture is that what's the anatomy of the lung? What are the basic structures that are going to be affected? First of all, we went into the congenital anomalies, in which we learned that what congenital anomalies would lead to what pathological structures inside the lungs, what pathological findings will happen. Then we went on to learn about the infections of bronchus and bronchioles. We learned about bronchitis, we learned about bronchioles, we went about if any of the ciliary work is compromised, how it will affect the whole system. So I hope to see you in the next lecture, and for learning more about pathology, do watch the other videos. Thank you for watching sqadia.com.